Perfect. So good evening or good afternoon to some. Thank you so much for joining us for our perioperative thermoregulation webinar. My name is Ashley Drain. I am a medical science liaison with Baxter in medical affairs. Part of my role is to bring clinical education and experiences to you all that can really be implemented into your clinical practices. And it's my pleasure to be your host today. So thank you again for joining. So before we get started, just to allow a few more minutes for people to join, I would love in the chat if you all can just say where it is that you're joining in from, what city, state, and also what role is it that you have in clinical practice. If you can just put that in the chat for us, we would love to learn more about our audience. I myself, I'm coming from Chicago, and very glad to be here this evening. Let's see. Wow, we have Los Angeles, OR registered nurse. Very nice. So we have the West Coast, we have the Midwest, we have Colorado, Broomfield. Very nice, very nice. So we have a bit from the West Coast and the Midwest. We'll see if we have some from the East Coast coming in. Wisconsin, beautiful, not too far from where I'm at. Surgical services educator, very nice. Charleston, South Carolina, very nice. Value analyst, nurse. Wow, very nice. Thank you all so much for joining. I'm so glad that you all could be here. We have Pennsylvania as well. Very nice. Awesome. So just with this up, we'll just go over a few things before we get started. So this webinar is being recorded and we will have the recording available afterwards. It is being sponsored by Baxter as a learning activity for you all. The presentation content has been fully developed by the presenter himself. All lines will be muted during the presentation, but we do have the option for the Q&A. We will have a Q&A at the end of the presentation. If during the presentation you have a question that comes to mind, please either enter it in the Q&A option or as well as the chat. I'll be monitoring the chat as well, so feel free to put it there as well. And if you have any medical questions related to medical information about Baxter products in particular, you can either reach out to the email address at medinfo@baxter.com, as well as you can go to the website medinfo.baxter.com. So now I have the pleasure to introduce our amazing speaker, Dr. Sessler. So Dr. Sessler has published more than 970 full research papers, including 36 in the New England Journal of Medicine, Lancet, as well as JAMA, which is the Journal of the American Medical Association. And more than 145 of his papers were accompanied by editorials, and more than 30 were cover articles for major anesthesia journals as well since 2010. And his papers have been cited 70,000 times in peer-reviewed articles per Scopus, and that's making him the world's most published and cited perioperative investigator, which is very exciting. He is among the top 0.01% of cited scientists in any field. And Dr. Sessler has been a principal or co-investigator on grants totaling $100 million. He founded and directs the Outcomes Research Consortium. The consortium is the world's largest anesthesia research group, and it publishes a full paper every other day for a total of more than 2,000 papers. So I'm very excited. Thank you so much. Please join me in welcoming Dr. Sessler.
Thank you, Ashley.
I will allow you to present. There you go.
Okay. Okay. Great. Well, it's my pleasure today to talk about perioperative thermoregulation, which is absolutely my favorite subject. Body temperature is normally tightly regulated. So every one of you right now has a core temperature that's within a couple of tenths of a degree of where your body wants it to be. As with many physiological phenomena, thermoregulation involves sensing, regulation, and then effectors. So sensation comes from all over the body. So the skin surface, but also deep tissues throughout the body, including the spinal cord and the brain. The highest level of control is in the hypothalamus, although other levels contribute. And then the primary effectors or defense mechanisms in humans are sweating, vasoconstriction, and shivering. So this figure plots the thresholds, that is the core temperature triggering each of these responses. And you can see that the sweating threshold and the vasoconstriction threshold are almost the same. They differ by only a few tenths of a degree. The range between the sweating threshold and the vasoconstriction threshold is cleverly called the interthreshold range. The interthreshold range is important, though, because it defines normal temperature. Normal body temperature is defined as the temperature that does not trigger thermoregulatory defenses, such as sweating or vasoconstriction. Please note that shivering has a threshold that's a full degree below the vasoconstriction threshold. So shivering is a last resort response, and by the time people start to shiver, they're already quite hypothermic. So this is the normal situation. Now let's look at what happens when you give anesthesia. So this figure shows the thermoregulatory effects of desflurane, alfentanil, dexmedetomidine, and propofol, so 4 commonly used anesthetic drugs. The first thing I'd like you to note is that we're dealing with a very expanded scale here. If you look at the y-axis, it goes all the way from 30 to 38 degrees. The entire figure I showed you in the previous slide would fit within the red oval in the upper left-hand corner there. So this is a very expanded scale. Now, there's a lot of information here, but I'm going to make it simple for you. First, look at the sweating thresholds. So those are the diamonds, and in each case, the x-axis is the clinically relevant range of drug concentrations. So in each case, over the entire range of drug concentrations, the sweating threshold hardly changes. Not much happens to sweating. And what that means is that even during a full general anesthetic, warm defenses are well preserved. In marked contrast, the vasoconstriction and shivering thresholds decrease substantially during anesthesia, and they decrease synchronously. What I mean by that is that the vasoconstriction and shivering lines are parallel to each other. For volatile anesthetics, the curves are nonlinear, so higher concentrations give you disproportionately more effect. For the intravenous drugs, the curves are linear. But in every case, the interthreshold range, that is, that distance between the sweating and vasoconstriction thresholds, increases markedly. So it is not true that anesthetized patients are completely poikilothermic. If you make them sufficiently cold, they will activate vasoconstriction. If you make them really cold, they will even shiver during a full general anesthetic. But it is true that thermoregulation is markedly impaired. The interthreshold range increases by, say, a factor of 10 during anesthesia. So very roughly, patients do not respond to thermal stimuli during anesthesia and act as if they're poikilothermic until they get to very low temperatures. So putting this together for general anesthesia, you have central thermoregulatory inhibition, has little effect on the warm defenses, but a dose-dependent increase in the interthreshold range results from the vasoconstriction and shivering thresholds decreasing substantially in a dose-dependent fashion. Results are similar in infants, children, and adults. And in very, very elderly people, say over 80, some of them have impaired thermoregulatory defenses. But generally, thermoregulation is a very primitive defense and it's well maintained. I'd like to go on now and talk about neuraxial anesthesia. So neuraxial anesthesia is spinal or epidural anesthesia. So in the case of spinal anesthesia, what we're talking about is injecting, say, 2 mLs of a local anesthetic at the base of the spine, which you would not think would do anything to thermoregulation, but it turns out it has profound effects. It has 3 effects, actually. The first is really curious. It's a central impairment of thermoregulatory control. So we see here that in these volunteers who participated once without anesthesia, once with spinal anesthesia, that the sweating threshold increased and the vasoconstriction shivering thresholds synchronously decreased. Therefore, spinal anesthesia, even though it's really peripheral to the brain, impairs central thermoregulatory control. Why this is not entirely clear, but it probably has to do with the fact that spinal or epidural anesthesia impair thermal input from the legs. Specifically, it blocks tonic cold input coming from the legs. Excuse me. The second problem with neuraxial anesthesia is that it impairs the gain and the maximum intensity of thermoregulatory defenses. The gain is simply how fast a response increases with further reduction in core temperature, and the maximum is just what it sounds like. It's the highest level that you can get to. That neuraxial anesthesia impairs shivering is unsurprising if you think about it, because it paralyzes the legs. So the legs cannot shiver even if the brain is telling them to. So what we see here is that without anesthesia, at a little bit below 37 degrees, people start to shiver, and as core temperature decreases, the shivering intensity increases very rapidly. So it's measured with oxygen consumption. You can see oxygen consumption doubles in just a few tenths of a degree. In contrast, with epidural anesthesia, the slope is much slower and the maximum intensity that it gets to is quite low. Furthermore, you see that shivering starts at a lower temperature with epidural anesthesia than with control, without anesthesia. That's the central inhibition. So you see the central inhibition as well as the peripheral inhibition on this plot. But there's a third problem. The third problem is behavioral impairment. The behavioral thermoregulation is everything that's not autonomic. So the autonomic responses are things like shivering, sweating, vasoconstriction that happen automatically and that are essentially not under our control. Our body just does these things. Behavioral thermoregulation is how you feel about your thermal environment and what you do about it. So behavioral inhibition or behavioral regulation includes opening a window, putting on a sweater, but also building houses and air conditioning systems and heating systems. The reason humans can live in the amazing diversity of thermal environments we do live in is because of behavioral thermoregulation. Behavioral thermoregulation is way more powerful than autonomic regulation. It's just that surgical patients can't activate behavioral inhibition very much. So it's not very helpful to them. What we see here is core temperature and thermal comfort on a visual analog scale in volunteers who were given an epidural anesthetic at 15 minutes, where the arrow is. So thermal comfort was on a 100 millimeter visual analog scale, with 50 being neutral, low temperatures, low visual analog scales being cold, and high being hot. So what we see here is you induce anesthesia and core temperature goes down. And I'll explain in a few minutes why this happens, but it's a reliable, predictable response. You give an anesthetic, whether general or neuraxial, core temperature goes down. But what's interesting is look at the visual analog thermal comfort scores. They go up. And in fact, the point where our volunteers said that they felt most comfortable had a thermal comfort score of 50, that is exactly neutral, exactly where they want to be, is when they had the lowest core temperature. So this is behavioral impairment. And what it means is that if you ask a patient with a spinal or an epidural anesthetic whether they feel warm, their answer has essentially nothing to do with their core temperature. You simply can't judge core temperature in somebody with neuraxial anesthetic by asking them because their behavioral responses are screwed up. Another phenomenon related to neuraxial anesthesia is that vasoconstriction during anesthesia is impaired by the neuraxial anesthetic. So patients given a general anesthetic alone will eventually start to vasoconstrict, and they will prevent further hypothermia. In patients who have a combined general and neuraxial anesthetic, they just keep getting colder and colder. So they're the ones who are at the greatest risk. So to summarize neuraxial anesthesia, there's a central regulatory inhibition for somewhat unknown causes. There's a peripheral sympathetic and motor block, and there's behavioral impairment. All three of these combine to make hypothermia during neuraxial anesthesia common. And in fact, for a given operation, the amount of hypothermia you get is the same with general and neuraxial anesthetic. This is not generally appreciated, but there is absolutely nothing protective about neuraxial anesthetic. Patients having neuraxial anesthesia get hypothermic just like patients given a general anesthetic. Let's go on now and talk about hyperthermia. So hyperthermia comes in several flavors. So one is excessive warming in extreme environments. So an example of that is a soldier in an impervious chemical weapon suit. Okay, these are often used in very warm environments, let's say the desert, the Middle East, and they prevent sweat from evaporating, so sweating becomes essentially ineffective, and the environmental temperature is high, and the result is that people become hyperthermic. And they become hyperthermic despite their thermoregulatory responses. There's nothing wrong with their thermoregulatory system except that the environment is extreme. So that's one way you can get it. A second way is to have moderate warming with regulatory failure. And this can happen with active warming during anesthesia. Sometimes you see it with kids, but more commonly it happens with drug-induced inhibition. So for example, atropine prevents sweating. And so if people take atropine, which they might in a neurotoxin environment where you're worried about chemical weapons and they're in a warm environment, they can become hyperthermic because atropine prevents their thermoregulatory defenses. Probably the most common way this happens is with party drugs. And people get hyped up on party drugs, which impair their thermoregulation, and then they dance. And because of the drugs, they dance excessively and for long periods of time. They generate a lot of heat, and they don't notice that they're becoming hyperthermic. And people kill themselves doing this routinely. Then another mechanism is excessive heat production. And the most common cause of this is heat stroke. So people go out and they exercise excessively in a very warm environment, and you get heat stroke. But the poster child from our perspective is malignant hyperthermia. So this is a rare syndrome where muscle get activated in a pathological way, and they generate 10 times as much heat as they're supposed to. And people, thermoregulatory systems are normal, but they simply can't dissipate so much heat. And so they become hyperthermic. So those are three mechanisms explaining hyperthermia. But by far, the most common cause of hyperthermia is fever. So let me make a distinction here. Hyperthermia is any abnormal elevation in body temperature. Fever is defined as a regulated increase in the thermoregulatory defense thresholds, or you can think of it as a set point. It has to be a regulated increase to be considered fever. So it's mediated by endogenous pyrogens, and prostaglandin E2 is a key mediator of fever. So in the perioperative settings, we get this from infection, but also non-infectious inflammation, allergic reactions, blood in the fourth cerebral ventricle, and other sorts of things. General anesthetics impair fever. So you can see here, these are volunteers who were studied 3 times, and each time we gave them interleukin-2. So interleukin-2 turns out to be an FDA-approved drug. It's used for renal cell cancer, but it's an interleukin, and it induces fever quite reliably. So if you look at the top curve, that's 0 MAC, so these are unanesthetized volunteers, we give them interleukin-2, and you see that they became febrile very nicely to about 38.5 degrees. With a low dose of desflurane, the fever was largely blocked, and with a high dose, fever was completely blocked. So general anesthesia doesn't just impair the responses to hypothermia, it also impairs fever. And that's why you don't normally see anesthetized patients becoming febrile during anesthesia. During anesthesia, they're fine, and then at the end, when you take the anesthesia away, then they become febrile in the recovery room. Opioids also impair fever, although not as well as a volatile anesthetic. Let me now talk about the treatment of fever. It's very tempting to treat fever with physical cooling. Now, of course, everyone first gives acetaminophen. It tries to find the underlying cause and fix that. But acetaminophen turns out not to be terribly effective for fever, and it's usually not possible to find and stop the underlying cause. So then you have patients who are febrile, so often in the ICU. What do? The temptation is to try to physically cool them. And let me propose that you don't do that. And this is the evidence for it. So this is another volunteer study where we induced fever in young, healthy, normal volunteers, and we either did nothing, or we actively cooled them, or we actively warmed them. In the gold type at the top there, you see that the integrated core temperature was essentially the same in all the groups. What this means is that the cooling is ineffective. So you cool people on the surface, you put ice around them or use some sort of active cooling mechanism. It doesn't actually work because thermoregulation is an extremely powerful response. And basically what happens is if you try to cool somebody who's febrile, they fight back and they vasoconstrict more and they start to shiver, and you make them absolutely miserable. So if you look at the bottom here of a severe cold sensation as a fraction of the time, patients who are actively cooled felt miserable. They were absolutely miserable, and it didn't actually change their core temperature. And oxygen consumption went up, the duration of shivering was high, blood pressure went up, catecholamine concentrations went up. So basically, if you have somebody who's febrile, give them anti-fever drugs like acetaminophen. By all means, try to find the cause. And unless they are approaching a temperature that's literally going to fry the brain, like 41 degrees centigrade, don't do anything. Just let them be febrile. Attempts to cool them will make them miserable and will not cool them. So to summarize perioperative hyperthermia, fever is regulated increase. That's the definition of fever. It's mediated by pyrogens. Anesthesia and opioids centrally impair fever, and use whatever you can to treat fever except active cooling. Let me now talk about intraoperative hypothermia. Hypothermia during general anesthesia develops with a characteristic pattern. So if you look at unwarmed patients having major surgery, you will see this curve very easily. There is an initial rapid decrease in core temperature, typically lasting around 40 minutes to an hour. This is followed by 2 to 3 hours of a slower linear decrease in core temperature. And finally, if patients get sufficiently hypothermic, typically about 3 degrees hypothermic or about 34.5 degrees centigrade, they reach a core temperature plateau and they do not become further hypothermic, more hypothermic, no matter how long the operation is and no matter how big the operation is. Each phase of this hypothermia curve has a different cause, and I want to run through them. The first phase is redistribution hypothermia. The key to understanding redistribution hypothermia is that core temperature is not average body temperature. Core temperature is just what it sounds like if you think about it. It's the temperature of the thermal core. So effectively, this is the trunk and the head. The peripheral thermal compartment, mostly the arms and legs, which by the way is about half your body mass, is distinctly cooler than core temperature, typically in a hospital environment 2 to 4 degrees cooler. If you think about it, there has to be a gradient between the core and the periphery, and then to the skin surface, and then to the environment. Because the second law of thermodynamics says that heat can only flow down a temperature gradient. If there's not a gradient, then metabolic heat, mostly generated in the core, would be stuck in the core, and core temperature would just increase further and further. Well, it doesn't normally. And the reason it doesn't is that heat generated in the core flows down temperature gradient to the periphery, then to the skin, then to the environment. Okay, normally the core compartment is relatively small, maybe half your body mass. But as I showed you previously, general anesthesia profoundly reduces the vasoconstriction threshold. So the moment you induce anesthesia, people vasodilate. And that allows heat to move from the core out into the periphery. This is not actually a net exchange of heat with the environment. This is an internal flow of heat, but it's a large flow of heat, and it results in this rapid reduction in core temperature. The second phase of the hypothermia curve, that is the slow linear decrease, is the simplest to understand, and it's exactly what you would expect. It results from intraoperative heat transfer exceeding, it's heat loss to the environment exceeding metabolic heat production. Most of this heat is lost through radiation and convection. Normally, conduction and evaporation contribute almost nothing. And then finally, when patients become sufficiently hypothermic, they again trigger thermoregulatory vasoconstriction. The trouble is that they have to get really cold, typically to a temperature of about 34.5 degrees. But once they do, they vasoconstrict, that vasoconstriction, even during anesthesia, is effective. It constrains metabolic heat to the core, and it prevents further hypothermia. Let's now talk about temperature monitoring. If you don't monitor core temperature, you will not know what your patient's temperature is. There is no way to know what somebody's temperature is aside from actually measuring it with a thermometer, preferably in a valid site. So there are 4 core temperature sites: pulmonary artery, distal esophagus, nasopharynx, and tympanic membrane, measured with a thermocouple placed on the tympanic membrane, which is not easy to do, and it's uncomfortable for patients. So effectively, because pulmonary artery catheters are not used very often, what we're talking about is the esophagus and the nasopharynx. Both are reliable core temperature monitoring sites. They are both resistant to artifact, and they're excellent. During general anesthesia, normally core temperature should be measured at one of those sites. However, during neuraxial anesthesia and in some general anesthetics, depending on the surgery, you may not be able to use esophageal or nasopharyngeal temperatures. So in that case, there are other sites that are generally reliable. They're not perfect, but they're generally reliable. And that includes the mouth, axilla, bladder, and zero heat flux thermometry. Temperatures that I do not recommend include forehead skin temperature, either compensated or not. And what I mean by that is if you measure skin temperature and your device adds a constant, say 2 degrees, that does not convert it into core temperature. Skin temperature is just not core temperature, even when you add a constant to it. Infrared, so-called tympanic thermometers, which actually don't see anywhere near the tympanic membrane, or infrared temporal artery thermometers are unreliable. And rectal temperatures, somewhat surprisingly, are also unreliable. Nasopharyngeal temperatures, as I mentioned, are excellent. It's a great site. I highly recommend using nasopharyngeal temperatures if you can't use the esophagus. But, and there's a caveat here, the caveat is that you need to insert the probe at least 10 centimeters. So 10 centimeters is quite long. It's longer than people think, and most people do not put the probe in nearly far enough. It doesn't matter if you put it in too far. If you put it in too far, it's still perfectly adequate, accurate. But if you don't put it in, if you put the probe in only, say, a few centimeters, you will not have a reliable core temperature. In infants, even in infants, you need at least 6 centimeters of insertion depth. So put the probe in a lot further than you think. I mentioned that rectal temperatures are inadequate. Rectal temperature, given long enough, will equilibrate with core temperature. The trouble is that long enough is not minutes as you would think. It turns out to be hours. And so rectal temperature simply won't help you when you need it most. So this is an example. So we took swine susceptible to malignant hyperthermia, and at elapsed time 0, we gave them halothane and succinylcholine. Well, in susceptible swine, this triggers malignant hyperthermia in a matter of minutes. And you can see that esophageal temperature started to increase in about 10 minutes, and it increased very quickly up to about 41 degrees. Axillary temperature also increased similarly. So either of those would give you good warning that something was going wrong, that your patient was not behaving normally, and that you should consider malignant hyperthermia. Now look at rectal temperature. So that's the second curve from the top. Rectal temperature stayed absolutely normal for 30 minutes and then decreased. And this has to do with high catecholamine load during malignant hyperthermia. So it was absolutely useless. So Normally, you measure core temperature because you're worried about inadvertent hypothermia. But malignant hyperthermia is a lethal disease. Survival is almost 100% if it's detected quickly and treated properly, and it's less than 50% if it's not recognized and not treated. Patients who have core temperature monitoring are 10 times as likely to survive an episode of malignant hyperthermia. So malignant hyperthermia is rare, but one of your jobs is to detect it and treat it. And if you're measuring rectal temperature, you will not notice it as quickly as you will if you're measuring true core temperature. Now let's talk about the consequences of hypothermia, because if there were no consequences, then we wouldn't worry about it. We'd just let patients get hypothermia. But it turns out that there are some consequences. So there is exactly one proven benefit of hypothermia outside of, say, circulatory arrest situations. Um, Hypothermia improves neurologic outcome after neonatal asphyxia. It does not improve lots of other ischemic conditions, such as aneurysm surgery, out-of-hospital cardiac arrest, in-hospital cardiac arrest, uh, um, sepsis, and other sorts of conditions. So all of these work in animals, and none of them works in humans. So complications are much more common. So minor complications are decreased drug metabolism, prolonged recovery, which is a consequence of decreased drug metabolism, shivering, and thermal comfort. Potential major complications are bleeding and transfusion, wound infections and prolonged hospitalization, and morbid myocardial outcomes. So let's go through them. So this is thermal discomfort. So this is thermal comfort. It's using the same 0 to 100 visual analog scale for thermal comfort. And remember, 50 is normal. 50 is when people tell you, I feel neither too hot nor too cold. I feel absolutely fine. Okay, this was about 200 patients who were randomized to be about 36.5 degrees at the end of surgery or 34.5 at the end of surgery. And by the way, this study was done in 1996, and at the time, 34.5 was the routine care group. This was normal in 1996, and the 36.5 group had experimental additional warming. What you see here is that the patients who were hypothermic, normal in those days, felt miserably cold, and it took them 2 full hours to recover to the point where they said that they felt thermally comfortable. Thermal comfort is distressing to patients. So nowadays, this is not so common. But when I started, hypothermia was absolutely routine. We didn't even have warming systems. All patients got hypothermic. And in pre-op visits, I would ask patients, have you had surgery before? And most patients have. They say yes. What was the worst part about it? Oh, doc, it was that feeling cold and shivering afterwards. Worse than the pain? Yeah, doc, it was worse than the pain. This is amazing. But somehow our brains forget the pain over years. The pain, even though it was terrible at the time, goes away. And people don't forget the feeling cold and being miserable because of the cold and shivering. Years later, they'll tell you, yeah, it was the worst part of surgery. It's amazing. But listen, if patients take thermal discomfort seriously, we need to. Okay, I admit thermal discomfort isn't going to kill anybody. But neither is nausea and vomiting. Neither is pain, for that matter. And we appropriately spend lots of time treating both of those. Well, here's something that patients take as seriously as pain and nausea and vomiting. Just for their benefit, we should take care of it and prevent it. because it's the right thing to do. I said drug metabolism is delayed. So this is an example with vecuronium. So this is, again, a volunteer study. People anesthetized twice, once at 36.6 degrees, once at 34.6 degrees. So exactly a 2-degree difference. And what's plotted on the y-axis is the duration of action of vecuronium. The duration of action of vecuronium in patients who were 2 degrees hypothermic was doubled. To put this in perspective, the duration of action of vecuronium in patients who were 2 degrees hypothermic exceeded that of pancuronium in a normothermic patient. Now, it turns out that vecuronium is far more effective than other drugs. So if you look at rocuronium, it's more like a 60% effect, not 100% effect. If you look at propofol, it's a 30% effect. But every drug we've looked at has been prolonged by hypothermia. We pay a lot to get very short-acting drugs because it facilitates our anesthetics. It just doesn't make sense to pay extra for short-acting drugs and then let patients get hypothermic and make your short-acting drugs long-acting drugs. As you might expect from delayed drug metabolism and prolonged drug effect, recovery takes longer. So this shows survival. It's a cumulative incidence for discharge from the post-anesthesia care unit. And so you read these curves from side to side. So you look at the difference in time on the x-axis between the normothermic curve in light font and the hypothermic curve in darker curve there. And the difference between these two averaged about 40 minutes. That might not seem like a lot, but remember, most patients stay in recovery for about an hour. If their recovery duration is prolonged by 40 minutes, that's actually a very substantial fraction of their normal recovery duration. Okay, so then we need to talk about the PROTECT trial. The PROTECT trial, by a factor of 10, is the largest perioperative thermoregulation trial ever. So it's 5,050 patients, multi-center randomized trial. All the patients were having major non-cardiac surgery lasting at least 2 hours. They were all over age 45. They all had at least one cardiovascular risk factor. They were randomized to 35.5 degrees or to 37.0 degrees. Our primary outcome was a composite of myocardial injury, cardiac arrest, and death, and secondary outcomes were surgical site infection, transfusions, duration of hospitalization, and readmissions within 30 days. Thermal management was excellent. And this is an important point because in any trial, if the investigators can't control the exposure, you wouldn't expect a difference in the outcome. So controlling the exposure is really important. Let me tell you, I looked at every temperature curve in every patient of these 5,000 some patients. And if sites weren't controlling the temperature carefully, they got a phone call. So the result was that we actually had super good thermal management. So remember, patients were randomized to 35.5 degrees or 37 degrees. Patients randomized to 35.5 degrees had an actual final core temperature of 35.6 degrees. Patients randomized to aggressive warming, that is 37-degree target, had an actual final core temperature of 37.1 degrees. We thus had exactly the 1.5 degree target difference. Here are the results. The primary result, remember, this is cardiovascular complications. Major cardiovascular complications is shown here, and you can see that not only was there no difference whatsoever, but the confidence intervals, 95% confidence intervals, were really tight. This is not an underpowered trial. This is an extremely well-powered trial that showed that there was absolutely no difference in the primary outcome. Furthermore, there was no difference in any of the secondary outcomes. So the results here were just absolutely neutral. And again, not underpowered. These are robust results showing that over the range from 35.5 to 37 degrees, the major outcomes that we evaluated are exactly the same. The results were similar in all predefined subgroups. Again, no difference whatsoever. So putting this together, randomization to 37 versus 35.5 degree core temperature does not reduce cardiovascular composite complications, did not reduce surgical site infections, did not reduce transfusion requirement, and did not reduce the duration of hospitalization or prevent hospital readmissions. So the study has limitations. We did not test thermal comfort, shivering, or delirium. Delirium wasn't on anybody's radar screen 10 years ago when I designed this trial. But what we can conclude is that in terms of major complications, intraoperative temperatures above 35.5 degrees appear to be safe. Let's now then go on to maintaining normothermia. That is, how do you prevent hypothermia? So one way is to increase ambient temperature. And as you probably know, you can keep any patient normothermic if you increase the ambient temperature enough. So this is done in pediatric operating rooms routinely. The problem is that enough turns out to be a temperature high enough to make everybody in the room miserable. So yes, you can do it. You can keep people normothermic by increasing the ambient temperature, but you won't make a lot of friends by doing that. And it's not a very sophisticated response. You don't need to warm the entire room because you can just warm the patient. So what this also shows is that if you use forced air warming, and resistive warming would work just as well, it doesn't matter, any sort of active warming, that ambient temperature no longer matters. And if you think about it, that actually makes perfect sense because what a patient sees is not the ambient environment in general. What the patient sees with active warming is the temperature of the active warmer. And so if you use active warming, it doesn't matter what the ambient temperature is. You can set the ambient temperature to whatever makes people comfortable, and that's a reasonable thing to do. Surgeons should not be thermally uncomfortable because it degrades their performance. They're there working. They have a job to do. Don't make them uncomfortable because it's going to make their performance worse. So it makes more sense to warm the patient and then leave the ambient temperature wherever makes people comfortable. You can also decrease heat loss by using insulating covers. And there are lots and lots of insulating covers in operating rooms. For instance, plastic bags, cotton blankets, cloth or paper drapes, or you can get special reflective sort of drapes that are supposed to provide more insulation. And what you see here is that all of these insulating covers are effective. Each of them reduced heat loss by about 30%, which is a clinically meaningful reduction, and that they were all about the same. So there were not important differences among any of these passive warming systems. And the reason is that the cover itself doesn't matter very much. What provides the insulation is that little bit of air that's trapped beneath the cover. And because it's the air that's providing the insulation, what the cover is doesn't matter so much. So do not pay extra for a special space blanket because they hardly work better than a plastic bag. Most patients, though, will require some sort of active warming. Um, Circulating water mattresses turn out not to be very effective, and they're pretty dangerous, actually, because they can cause what's called pressure heat necrosis. So they are fortunately rarely used anymore. Forced air is perhaps the most common sort of intraoperative warming mechanism. And as you can see here, it works very well. Resistive heating is another option. So this is one example showing that resistive heating and forced air heating were comparably effective. There is no important difference here. The differences between these curves are a tenth of a degree. It's meaningless. So resistive heating was just as good as forced air. In this study, we have done at least 3 other studies with resistive heating, each of which showed exactly the same thing. So resistive heating or forced air are comparable. You can use either one. There's one other way to reduce hypothermia during anesthesia, and that is pre-warming. So pre-warming is a way of preventing redistribution hypothermia. So remember, in the beginning, I presented the 3 phases of the temperature curve, the first one being this very rapid reduction in core temperature during the first 40 minutes or so of anesthesia that results from this large core to peripheral flow of heat. It's very hard to treat redistribution hypothermia because it's this large internal flow of heat. Nothing you do to the skin surface gets heat into the core quickly enough to make a difference. But you can, to some extent, prevent redistribution by pre-warming patients. So what I mean by this is, say, 20 to 30 minutes of active warming. It has to be active warming. You can't just cover people with a blanket. You have to use active warming that actually transfers heat across the skin surface. And you do this ideally, say, for 30 minutes or so. Core temperature does not change because we haven't induced anesthesia yet, and core temperature is still tightly regulated. So core temperature stays exactly the same, and therefore the heat content of the thermal compartment, the core thermal compartment, stays exactly the same. But you are, during this 30 minutes, transferring quite a bit of heat across the skin surface. All of this heat goes into the peripheral thermal compartment because we just said it's not going into the core. So the only other place is the peripheral compartment. And what it does is it raises peripheral thermal compartment temperature, tissue temperature, and heat content. Then when you induce anesthesia, there is only a small gradient between the core and the peripheral thermal compartments. So remember the second law of thermodynamics. Heat can only flow down a temperature gradient, and the amount and rate of heat flow is proportional to the gradient. In a small gradient, there simply isn't much flow of heat from the core to the periphery and not much redistribution. So this has been tested in many studies. This is our meta-analysis. There's absolutely no question pre-warming works. The trouble is it doesn't work very well. So you can see the average reduction in redistribution hypothermia was less than half a degree, which is generally not a clinically meaningful difference. One other thing I want to talk about is fluid warming. So you cannot keep people warm by warming fluids. And the reason is that you can't warm them to much above core temperature, but you absolutely can cool people by giving cold fluids. So 1 liter of crystalloid at ambient temperature reduces mean body temperature by 1/4 of a degree. 1 unit of blood from the refrigerator also reduces mean body temperature by 1/4 of a degree. It's half the volume and it's twice as cold. So corollary is it does not make sense to give, say, 4 liters of unwarmed crystalloid and then hook up a fluid warmer to give 1 unit of blood. If you're giving lots of fluid, whether blood or crystalloid, use a warmer. But by lots, I mean over a liter per hour and for a long time. So let's say 3, 4 liters, then it makes sense to warm fluids. Otherwise, it's just a waste of money. So to summarize here, the rule is you need to monitor core temperature, because if you don't monitor, you will not know what the core temperature is. And you need to keep patients at least 35.5 degrees, because the PROTECT trial shows that temperatures above 35.5 are safe. I don't care how you keep people warm. Forced air or resistive heating are both effective. Both have been evaluated in lots of studies, lots of different systems. They both work. I really, really don't care how you keep people warm, but I do care a lot that you keep them warm. It's your responsibility. Thank you much.